Okay, well, I'm going to talk to you. It's called a research update, but it's just I picked out a few papers from the IACFS conference that Sarah and I attended about 3 months ago, 2 to 3 months ago. And it was a very busy 3-day conference, and obviously I can only present a few little snippets, and it is available for you to read if you require the whole thing. Next slide, please. First of all, has that moved on, that slide?
What was that, sorry?
Did you move the slide on?
Yes, I did. You need to go further along.
Yeah. Okay, so the conference opened with an address by a man called Avindra Nath, who is quite a high-powered person, a very high-powered person in America. And his particular interest is in long COVID. That's how he got involved, really. And he's saying, of course, that these two conditions, long COVID and ME, are probably much the same. And the particular types of symptoms that you see in both will be the exercise intolerance, the brain fog, the POTS, which is the feeling lightheaded if you stand up for any length of time, as a number of other symptoms too, and myalgias, which are muscle and joint pains particularly too. And so they've shown that the phenotypes overlap with both COVID and ME, and two mechanisms have been proposed. Persistent infection, which may be still going on for people who have this post-viral type of illness, which for many people with ME has lasted a very, very long time. There may well be also immune activation with the T cells, which are one of the types of white cells getting overworked and exhausted. This has been described in the ME world for a long, long time. So moving on now at the next slide.
Can you just hold on 1 second, Ros? Angela, you need to go back. Yeah, so she was just talking about the one before. So just
right.
Well, so we can see that one before.
Yeah, that's
that one. So that's what Ros has just been talking about, and now you need to go on to the next one.
Okay, we can go on to the next one now.
Yeah.
So he talked about treatment possibilities that are being looked at, certainly mainly in the States, of course, from his point of view, but worldwide, I think. And antiviral agents may well be appropriate, both in COVID and in ME, if there seems to be persistent infection. Medication that settles down the immune system, and also treatments that may improve the exhaustion of the T cells, which are the natural killer cells. And he said, of course, clinical trials are needed. And what is going to be happening now in the States, of course, is money being poured into long COVID, which can only surely spill over into the world of ME. So, you know, although we don't like the thought of long COVID being around, it's having some benefits for ME groups, ME research groups around the world. Next slide. The next presentation, one of the next presentations in that particular slot was comparing the ME and the CFS with the long COVID from an immunological point of view. And this woman, Anna Gell, presented evidence, and she had found evidence of viral persistent in both types of illness. Felt the symptoms themselves are probably due to the dysregulation of the immune system, and of course the hyperactivity of certain aspects of the immune system seems to wear out these so-called T cells, so they're no longer able to function as efficiently as they should be. And the ratio between the various sorts of white cells have been shown to be altered and activated. So she is focusing very much on encouraging treatment strategies which are going to modulate or help the immune system. Next slide. John Shear is a gastroenterologist from California who's been around for a very long time in the ME world, and he particularly attracts patients with ME who've had what we call an enterovirus infection. This is a viral infection involving the gastrointestinal system, and he looked at his ME patients in this category who had then gone on to catch COVID-19, and he followed them up for 6 months, and he found it made a considerable worsening of their ME symptoms, and some people became very, very seriously ill. The effects seemed to go on for a very, very long time. So a person who might have had just moderate ME could well have become then very, very severely ill, and how long that will last is still unknown. And about 1 in 5 of them did need to be admitted to hospital, and a lot of them would have needed artificial respiration. And they were treated with an antiviral agent called remdesivir and steroids. So that did help quite a bit with symptoms. And again, one has to be saying, okay, is this kind of treatment perhaps therefore suitable for ME patients, nothing to do with COVID? Again, it's raising possibilities, raising questions. Next slide. Christian Sommerveld comes from Bergen in Norway. And of course, Bergen is the place where there have been a lot of research studies done looking at treatment. I'm sure many of you will have followed that over the years. The team that have used, the team of oncologists who've used treatment for ME patients. Anyway, Christian showed that looking at the severe and very severe cases, and they're able to come up with 491, which shows a very large percentage of people. But the majority of very severe cases had their onset of illness before the age of 15. So they were very young people, about 77% of them, and many were bedbound and had remained bedbound for a long time. Duration of illness of often more than 15 years in about half of them. These people were very severely ill, unable to do much at all, and particularly suffering from fatigue and muscle pain, joint pain, sensitivity to noise and smells and visual sensitivity and so on, and a worsening of symptoms after very minimal activity. So they may well just have got up to go to the toilet and then be really flattened for a long time. And he particularly talked about the burden for carers. This would often, of course, with the young people, have been family members, parents, who would have been spending up to 40 hours a week just caring for the person with the severe ME. And so the carers often developed quite serious effects on their own mental well-being. So quite an important study, really, showing how very serious this illness can be. Next slide, please. We moved on then, and I mean, I'm dodging all over the place because I've just picked out things that I felt were interesting for you. There's a drug called aripiprazole, which has been, kind of bandied around as a possible treatment for this illness. And Professor Bonilla from Stanford University presented some interesting aspects of it. Interestingly, the British ME Association have strongly advised doctors not to use this drug because it's unproven and it's potentially a very dangerous antipsychotic drug. When you look at the list of side effects that are listed associated with it, it's almost like getting very severe ME all over again. So, you wouldn't really be wanting to cause extra symptoms. So I think until the drug has been proven as potentially possibly useful, it won't be used by many doctors as yet. However, he presented the one patient that had been treated with up to about 2 milligram, which is a reasonably high dose of that particular drug. And there was dramatic improvement in the MECFS over the course of about a year, really dramatic improvement. So this, of course, created a lot of interest. At Stanford, then they gathered 100 more patients and treated them with a smaller dose of about 1.2 milligram. And 3/4 of that 100 did have some level of improvement, not necessarily dramatic, but certainly some improvement, particularly fatigue and brain fog, sleep things. So it looks like there is potential, but we're still in the early stages of research. So one shouldn't be rushing in to be asking the doctor for this. They think that it may have various ways it's working, may decrease the cytokines, which are the immune system active chemicals in this illness. It may be that the microglia, which are the inflammatory white cells in the brain, are improved upon. The immune system may be generally some of the abnormalities reversed. And then they talked about dopamine mediated mechanisms, which I'll tell you a little bit more about in a moment. But we had to ask the question, had the patients who improved a lot been actually also suffering from some underlying psychosis, because this is an antipsychotic drug? And obviously further trials could be undertaken. But how does dopamine fit in? Next slide. Dopamine is what we call a neurotransmitter, which is a chemical which helps the passage of neurological functioning, and your body prepares and makes it, and your nervous system uses it to send messages between nerve cells. And it plays a role in how we actually feel good. It's a big part of the way we think and plan and get on with life. So we do need it. It's not a drug in itself. You can't just swallow it, much as though it sounds wonderful. But there are drugs which do promote it. But it's best promoted by sensible lifestyle and doing things like relaxation, promoting good sleep, getting some sunshine and vitamin D, eating properly, exercising sensibly, and so on. So all the things we normally recommend for patients with chronic fatigue syndrome tend to be things which will improve dopamine. So maybe deep down, this is one of the reasons we sometimes find people do feel much better when they take on board a sensible, good lifestyle. Next one. Peter Rowe is from Baltimore, though he is actually a New Zealander of long ago, but he's been professor of pediatrics and medicine in Baltimore for a long time. And he talked about cranial instability, which some of you probably have had some clues about. The film Unrest, I think it's thought the woman star of that would have had this problem. And this particular patient that Peter presented had been diagnosed with ME, Ehlers-Danlos syndrome, and POTS. She'd also had an accident which caused some problems with her neck, which led to some instability of those vertebrae right at the top of your neck, where your neck joins onto your skull. And this can cause some compression of the lower part of your brain, upper spinal cord, and it can lead on to a lot of symptoms, worsening fatigue and more POTS symptoms. And certainly a number of ME patients have wondered about this and wanted to be investigated, because the symptoms, of course, are very much the same. And I've had patients who've been off to see neurologists and neurosurgeons. I haven't actually had any patients who've had surgery for this, but a lot have had surgery with varying levels of success or not. But this particular patient that Peter presented talked about the fact that physiotherapy with work on the neck muscles was extremely helpful, and I think the patient eventually did have some surgery with quite a good outcome. Next one. Then the next 3 slides really talk about what we call post-exertional malaise, PEM. A lot of you will be very, very aware of that. The core symptom really of ME/CFS, in that one feels completely exhausted and often ill after what is maybe a very minimal amount of exercise. And this is certainly recognised now as one of the particularly characteristic things we see in people with this illness. And if a person doesn't suffer from post-exertional malaise, you have to ask, in fact, do they even have ME/CFS? Anyway, Todd Davenport and his team in California have been for quite some time doing what we call CPET, which is cardiopulmonary exercise testing. This is putting people on an exercise cycle. Most ME people who are well enough do reasonably well at the first testing, and then they come back 1 or 2 days later for a second test and were found to almost be hardly able to get on the bike, let alone perform. Well, Todd, felt that certainly this second test was in some ways almost cruel, so looked at what would happen if you just did the one test and sort of see if you could use this more or less as a diagnostic test for ME, because it's very characteristic. And he found that if a person did not seem to recover from that first test reasonably quickly, probably within about 48 hours, maybe 3 days, then they were 11 times more likely to have ME/CFS. And this really is almost like a diagnostic test, a clinical prediction tool. And particularly the 2 symptoms he was looking at were post-exertional decrease in function, which is the PEM, or a lack of positive mood in response to exercise. Excuse me. So that, I think, is very characteristic way of separating the ME patients from those who are depressed, because a person who is depressed will feel really good with exercise usually if they can be encouraged to get up off their bum and do the exercise, but it really does usually make them feel good. They get an endorphin release, and we know that this is unlikely, therefore, to be a patient with ME, chronic fatigue syndrome. You do, of course, get mixed bags, and you can get people who are both depressed and suffering from ME. So there's always confusion on people, but on the whole, this was looked on to be a good way of sorting out. And another person from Cornell in the United States had looked at about 60 patients, 45 controls, who were healthy people, and they all undertook the cardiopulmonary exercise test, had blood samples taken before and after, looking at what we call metabolomics, which is the basic chemistry of your body. I'm sure Warren would enlarge on it far more exactly than I can, but if you think about it as just the changes that are going on in your body all the time, depending on what you're up to, what you're doing. And he compared this between patients and controls after the exercise test and found that the patients had a very definite difference. And this was likened a little bit to the hibernation, or what is known as DAUER, D-A-U-E-R. And it's a sort of sign that the metabolism is on go slow, really, I suppose. And it was very characteristic that people with ME/CFS were very like animals in hibernation. So maybe that's familiar to some of you. They also developed study to show that there were some unknown or new chemicals that they discovered, and they're furthering their work in that field. And a third one on exercise testing was a breath of fresh air for me and Sarah, because it was Lynette Hodges from Palmerston North here in New Zealand. And she showed again that patients who were exercising with CPET testing were only able to achieve about 84% of what they should have been able to achieve with their heart rate and blood pressure. She challenged them for 5 minutes on an exercise cycle, and the recovery phase was very, very slow, quite abnormally slow. And I think, you know, the message coming across from her presentation and the other two, and various others as well, that exercise needs to be extremely cautious for people with ME, because obviously it can lead to postexertional malaise and even a very serious relapse if they're pushed hard. And I think it's really exciting and encouraging that since this conference, although it was nothing specifically to do with it, but the British NICE guidelines have now removed graded exercise therapy from their guidelines for patients with ME/CFS. At last they've got the message, and I think this is going to spill over worldwide, that exercise is not the way to treat this illness. Yes, people do need to move around and not turn into jelly because they do nothing, but they do need to be very, very cautious and pace any approach to exercise very, very carefully. Next slide. This is an extra slide I poked in, and it was nothing to do with the conference actually, but because I've been asked about it so often, I just thought I should talk a little bit about low-dose naltrexone, which probably many of you have heard of and may have even tried. Naltrexone is a very old-fashioned drug which used to be used mainly, and still is, in high doses to treat people when they're trying to come off addictive medication or addictive drugs of various sorts. But in, I don't know, probably 8 or 10 years ago now, the rheumatologists found that very tiny doses of naltrexone could be helpful for the chronic pain associated particularly with fibromyalgia and other symptoms too. So it's become quite well used now in the ME world, and many patients are wanting to try it. So I'm using it quite a bit. We need to discuss the option carefully with the patient, pointing out potential side effects, benefits, and so on, and also check that other medication used isn't going to be causing a conflict. I usually would recommend starting about 1 milligram a day, tiny amount, and this can be increased slowly over time, maybe an extra milligram a month or an extra milligram a week anyway, depending on the person's how they're doing. It can go up to about 9 milligrams for this kind of issue, but usually I would stop at about 4.5 milligrams. Most people find beyond the 4.5, they do begin to get some side effects. There is a bit of a risk of insomnia, which of course is always a problem anyway. So usually say starting in the mornings and only changing to evening taking if the person feels kind of sleepy all day on it, which some do, but the majority will prefer morning taking. They need to persevere, taking up to about 6 weeks before it shows benefit. And of course, there is a cost. You have to pay for it. And I think we're talking about $70, $80 a month. There will be a lack of response. If I took, 100 people, about 1/3 would be doing reasonably well on it. About 1/3 wouldn't have any benefit whatsoever. They say, well, it did nothing to me. And about 1/3 will not be able to tolerate it because of side effects. So, it's not the be all and end all, but it's a possibility. And it certainly doesn't fix the illness. I think it's important to realize that it takes away some of the symptoms for some people. So it's not absolutely so wonderful that you have to rush off and get it straight away, but it's a useful option for the doctor to have as a possibility. And, you know, for someone like myself who's perhaps prescribing it, really important to communicate with the patient's GP so that everybody's in the know of how to manage it and so on. And I produced an information sheet for GPs because a lot of them have been asking about it. So I thought I'd throw all that in because it's fairly topical. Last slide. And overall, going back to the conference, it was really informative and worthwhile attending, even though for Sarah and I, it was 3 nights through the night. So it was a pretty hard going situation. But, you know, the conference was so stimulating, it kept us awake. And ANZMES did provide us with some lovely snacks too. Many other papers were presented, and the overview is available on that website. And I would imagine that Angela could put you in touch with getting that overview or even a printed handout. But I'll be happy to answer questions. I think we're doing that at the end of all the presentations. So I'll finish now and be ready to pass on over to the next person.